Moss Adams is pleased to present another in our ongoing series of continuing professional education webcasts. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize both how you view our presentation and how you interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. For example, you can click the file folder icon to download the group attendance sheet and a PDF copy of today's slides. You can ask our presenter questions during the webcast by clicking Q&A in the bottom left-hand portion of the icon bar and typing in your question. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. We'll ask polling questions throughout today's presentation. Per the National Association of State Boards of Accountancy Webcast CPE standards, CPE credit will be awarded based on your participation in these polls. To respond to a poll, click the button next to your answer. If you're attending this webcast in a group, in order to receive CPE credit, you must complete our attendance sheet, available in the file folder icon at the bottom of your screen. Please have all group members sign the sheet, and please remit only one sheet per group. Also note, today's session will offer you one CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. CPE credit can be awarded only to participants registered as themselves and is not available to participants who view the on-demand version. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon to open a PDF file you can save to your computer. We'll email a copy of your PDF certificate in 2 weeks if you can't download it today. As a reminder, the presentation you're about to see is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
Good morning and welcome to today's webcast, Hospital Site Neutral Payments for Off-Campus Outpatient Departments. We have three great speakers joining us for today's presentation, Larry Vernaglia and Jennifer Walsh of Foley and Lardner, and Cheryl Storey of Moss Adams. Larry is a partner and healthcare lawyer with Foley and Lardner and serves as chair of the firm's healthcare industry team, named Health Law Firm of the Year for 3 of the past 4 years on the U.S. News Best Lawyers, Best Law Firms list. Mr. Vernaglia represents hospitals, health systems, and academic medical centers, and a variety of other healthcare providers. Jennifer is a public affairs director with Foley and Lardner. She has extensive experience in government affairs, including a lengthy career as a senior staffer in the U.S. Congress and the California Legislature, and as a vice president for federal government affairs at a top 20 Fortune 500 healthcare company. Ms. Walsh has effectively advanced key issues before the United States Senate, House of Representatives, and the administration. She is a member of the firm's government and public policy practice. Cheryl has built her experience in the healthcare field for over 30 years. She focuses on various Medicare and Medicaid reimbursement issues and related billing and coding issues. Cheryl has worked with healthcare providers on graduate medical education programs, compliance with CMS's provider-based requirements such as signage, attestations, and certification and licensure of the provider-based departments in conjunction with the applicable state departments. We'll now turn the line over to you to get us started.
Thanks, Emily, and good morning or good afternoon. Welcome to all of you joining us today. The topic of our time together is going to be the big changes that have taken place in hospital outpatient reimbursement under Medicare in the last couple of weeks. We have a few significant developments, many of which you've been observing, I'm sure, over the last year or so. We will have a time for some questions and answers at the end, and you're welcome to ask them live, I guess, or through the webinar window, or if you're concerned about the privacy of it, feel free to email any of us, Cheryl or Jennifer or me, and our email addresses are right there, and we'll pick them up during this session. Finally, at the end, we'll email you a copy of an e-alert that the three of us just published and that went into your inboxes if you're subscribed to our mailing lists. If not, you'll at least get that, and you can sign up anytime you want. So what we're really going to focus on today will be, I would say, 2 key developments, but principally the Medicare proposed rule. But before then, we're going to set the CMS published early last month, relating to their views of provider-based facilities and what CMS ought to do differently with them, in some respects mooted by the changes in the Bipartisan Budget Act of 2015, or BBA, at Section 603, and the proposed rule that CMS just published to address their efforts to implement the statute. We note now, and we're going to tell you at the end, that there are comments welcomed. As of September 6th is the deadline. We urge you to submit your comments as we have all along, but this time we really mean it because this is one of your last chances. And Jennifer will conclude our remarks today by talking about how those chances look. I guess, Emily, we have our first polling question. You want to do it for us?
All right. So the first question of today is, does your organization have off-campus hospital outpatient departments? And your options are 1, 2 to 5, 6 or more, or none at this time. And I'll give everyone a few moments to respond. To participate in the polls, please click the button next to the answer you choose and hit submit. And let's take a look at the results.
All right, thank you, Emily. 6 or more. We know a lot of clients that have many more than 6, and they're just trying to get a handle on all the locations. So I'm going to go over what the OIG discussed in the provider-based report. It's dated June 6th, last month, just 1 month before CMS publishes the calendar year 2017 OPPS rules on what they want to do with provider-based entities. So like Larry said, it's, I think CMS did implement some of these things. So the OIG says, half of all hospitals have at least one PB entity. Most of the people on this webinar have more than 6. The OIG believes there's vulnerabilities that exist in compliance with PB regs. Well, we agree. I think there's a lot to consider when you're going to be provider-based and just make sure you're compliant with all of those. But the OIG wants CMS to improve its oversight of provider-based facilities. CMS doesn't necessarily agree with the OIG on all of their findings, and CMS hasn't provided the OIG with any evidence that provider-based facilities produce specific benefits, such as integration or improved quality of care, but CMS wasn't tasked with or even required to track this data. CMS cannot identify the number of hospitals billing as provider-based. Well, that's because there's no database that exists as to what's provider-based and what's not, and the UB04 claim form that hospitals use to bill their facility services for those provider-based departments does not indicate a location of services. So the OIG had done a random poll, selected 333 hospitals, and then selected 50 hospitals for their sample, and used those 50 hospitals in their report and are applying their results. So the OIG was subjective in their standards and didn't cite specific reasons or examples of violations. They just say these facilities may be billing Medicare improperly and may be receiving overpayments, but didn't have anything quantitative to share. So one of the ways a facility may be billing Medicare improperly may be with your place of service code. You're supposed to use 19 for off-campus and 22 for on-campus provider-based. And sometimes we've even found our provider-based facilities billing place of service 11, which indicates a freestanding entity, and then no facility charges billed. So then the OIG wants CMS to take appropriate action against the select number of hospitals, sample of 50 that the OIG says was out of compliance. The OIG said that 39 of the 50 hospitals sampled had not even submitted voluntary attestations. Not that they're required, the word is voluntary. So CMS responded on February 29th, 2016. They concur with the OIG's recommendation to implement systems and methods to monitor provider-based facilities, which we will discuss further in this webinar. CMS believes it's not prudent to spend resources on distinguishing provider-based services on campus versus off campus, but under the new proposed rules, I think that that's going to be coming about. CMS doesn't agree hospitals need to submit attestations. They want to keep that voluntary. But CMS does concur with the OIG on ensuring regional CMS offices and the MACs apply the provider-based requirements appropriately. We want to ensure that they apply them consistently across all MACs, all regional offices. So CMS has not yet developed a list of specific documents to be submitted with the attestations. We've worked with clients on helping them determine which documents to submit when they do the voluntary applications. And interestingly enough, Appendix E of the OIG report lists the number of attestations that have been approved by each CMS region as of 2012. It's far less than I would have expected. So next is, go ahead.
Before we move on, I think one of the takeaways from this is looking specifically at the violations OIG seems to have found. Some of them are things that you might not have a lot of confusion about. The distance to the facility, is it on the license of the facility, things like that. But others are highly subjective and subject to differing opinions based on, who's the surveyor, who's the auditor, and what level of compliance are they looking for some of these issues. And so you didn't give the kinds of examples of violations that the industry might like. It's difficult to tell whether they were looking for a piece of paper to prove that the violation had not occurred, or whether they had looked at everything and on their own determined that a violation had occurred. We may need to wait for that separate memorandum from CMS to figure that out.
Good point, Larry. So now, with that, here we are going to start the OPPS 2017 comments and what CMS is proposing. So we want to indicate the Section 603 relates to services furnished at certain off-campus outpatient departments. And Section 603 is going to pay for those services at other payment rates rather than under OPPS or APCs. So this is supposed to be effective for items and services furnished on and after 1/1/17, and we'll see how easy or how difficult that will be to implement. CMS refers to your off-campus departments as off-campus PBD, so we will use that terminology throughout this webinar. And note this is applicable to off-campus provider-based departments that were not billing as hospital-based prior to November 2nd, 2015. And Jennifer will close with what Congress is trying to do to determine whether a hospital was billing or not billing, or whether they can be grandfathered under this section to avoid being treated as certain off-campus facilities. So they will be paid under the applicable payment system under Medicare Part B, and CMS discusses the Medicare physician fee schedule in the proposed rules. So CMS is going to need to establish a new payment policy for certain items and services furnished at these off-campus departments. And note, this is the proposed rule, and the final rule tends to come out sometime in November, and it starts on 1/1/17. So we'll see how much change from the proposed to final happens with CMS. So implementation, CMS indicated there's no legislative history on record regarding Section 603, but the Congressional Budget Office estimated a program savings of $9.3 billion over 10 years. How they came up with the $9.3 billion, we don't know. So in this proposed rule to try to deliver on this $9.3 billion, CMS is defining applicable items and services that will be paid as hospital outpatient services. They're going to further define off-campus provider-based departments, and they're going to establish policies for payment for the applicable items and services furnished at these off-campus PBDs. And which services are accepted from Section 603 that can continue to be paid under OPPS. And CMS does use the word accepted in the rule versus grandfathered, but it does mean the same thing. So it's a little bit of a tongue twister trying to use the word accepted throughout. So with that, we've got our next polling question. Emily?
Thanks, Cheryl. Our second polling question is, how many of your clinics will be subject to the site-neutral payments as proposed by CMS in CY 2017 OPPS rule? Your options are 1, 2 to 5, 6 or more, none at this time. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. And let's see what we've got.
Wow. Well, Larry, I'm going to turn this over to
Cheryl,
you. Yeah.
I know that I participated in writing this question, but I think it was a trick question, because the more we read the proposed rule, the more I realize that even the grandfathered facilities are going to be subject to some of the provisions of the proposed rule if it goes through. And maybe I want to kick it off just with that big picture. Jennifer and Cheryl and I are going to be providing you all with the details of the proposed rule now. But let me offer a few comments on big picture here. I think that, in editorializing, this proposal is largely negative for the hospital industry if it's implemented as planned. Big picture takeaway is this is going to cause all of your off-campus provider-based departments, other than those that are dedicated emergency departments, we're going to talk about that, to be effectively frozen in time and potentially subject to the whim of your landlords if you have them. There's very little flexibility for future growth or change in strategy. And if there was one message that you wanted to communicate to your senior management team or your board, it would probably be that. Cheryl, did you want to add to my editorialization or distance yourself from it?
Oh, no, I totally agree with you.
So, this number this is probably a trick question. We probably meant to say all of them. At least it appears to be the case. Let's now start walking through some of the details that are going to be important to you. One of the most important definitions in the statute and now the regulations is the definition of on-campus versus off-campus. The statute and the regulation only apply to off-campus PBDs, as Cheryl said in the introduction she just offered. And so your on-campus PBDs can do basically business as usual with the Medicare program. What I think that's going to mean is that a lot more hospitals are going to say, well, the heck with this, I'm just going to start building up on campus, which is not necessarily the most efficient use or allocation of resources, and sometimes not even possible, but so be it. With respect to what is the definition of on-campus, and a number of our clients have reached out to Cheryl and Jennifer and me about that very topic, CMS has really offered no changes to their historic definition of what's on and off campus, located within 250 yards of the main buildings, and what part of the main buildings is somewhat subject to some regional variations. We think that those variations are getting a bit refined as the Medicare Administrative Contractors, or MACs, and regional offices are thinking about it. But one thing to pay attention to is exactly how close your building will be. And if you're on campus, you're going to be safe from these, and if you're not, you're subject to them. The regulation also has probably the clearest statement of the prohibition on multiple main campuses, which a number of hospitals have relied upon for various reasons along the way. You know who you are if you're one of them. And we can share that language with you if you're interested. There are a variety of statements in the proposed rule about what hospitals need to do to add an off-campus PBD. In fact, they specifically instruct the provider community to add these locations with an enrollment form, although we note that the attestation process, as Cheryl mentioned, remains voluntary and is still voluntary despite what OIG might have wanted to do. And there are certainly a lot of judgment calls at these days about whether you want to submit an attestation, at least for a off-campus PBD. Cheryl also mentioned some of the new modifiers. She referenced the new modifier 19. I'm glad that comes as easily to her as it does to me. It doesn't get to me. But you're going to learn about the new modifiers for outpatient hospital off-campus versus on-campus, if you haven't already, because they've been required since the beginning of the year. One of the, so as I've said, that the agency is not changing their definition of what's on campus or off campus, but one thing they did do, which was very interesting to me, is the statute specifies that a PBD that's within 250 yards of a remote location of a hospital, which is another inpatient site somewhere away from the main campus, is also treated as on campus and therefore protected from site neutrality. This is a very important provision, and already a lot of planning is going on around this area. And what's important to me is in the proposed rule, CMS says that 250 yards from the remote location can be from any point of that remote location. Yet they don't have that level of clarity with respect to the main campus. I'm sure that providers will be using that to argue by reference that any point of the main campus is also viewed as on campus, particularly in those jurisdictions where MACs are coming up with their own determinations of what on-campus and off-campus means, some of them arguing that it's from a patient care entrance, others from the emergency department entrance, and so on. We believe that the MACs and the regional offices are huddling to come up with some common rules. But we wanted to start with that big picture issue to make sure that you all understand that the only buildings that are subject to this new site neutrality limitation are going to be those that are off campus. So our next topic then is one that I alluded to a moment ago relating to dedicated emergency departments. In addition to the protection for buildings that are on campus, Congress provided broad protections for dedicated emergency departments or emergency departments, even those that are off campus, from site neutrality payments. And what CMS did, and I think that it was a good and thoughtful regulatory position, is make clear that all the services in the DED are going to be exempt from site neutrality, even if they're non-emergency services. This is an important distinction, and I think that it'll cause a lot of providers to evaluate whether or not they have a DED or not, or whether they want to make sure their facilities can be DEDs or not. The definition of a dedicated emergency department comes from the EMTALA, or the patient anti-dumping laws, years ago. And in fact, at the time that Congress pulled this definition in, they pulled in the regulatory definition from EMTALA. But when EMTALA was converted into regulation, CMS or HCFA's goal at the time was to drag in as many buildings as possible under the protections of EMTALA so that patients would have the protections of the law. And so the definition of a dedicated emergency department is actually quite broad, including simply being held out to the public as a place that provides care for emergency medical conditions on an urgent basis without an appointment, among other things. So if DEDs become an important safeguard to protect against site neutrality, you may find some planning in the future about that. Cheryl, let's talk about some of the other things that may not have been as easy to implement as the DED rules, if we could, in the new proposed rule.
All right. So let's talk about departments that are accepted. Hello? Departments accepted from the 603. Relocation. Off-campus provider-based departments billing as outpatient departments of the hospital before November 2nd are not subject to 603, but as Larry said, they're fixed in time as of that date. So what happens if you relocate your accepted? See, this is the tongue twister part, your grandfathered department. CMS is very strict. If you relocate that provider-based department, you're no longer accepted from Section 603 if you move or relocate from the physical address on as provided on your enrollment form. And CMS has indicated in the proposed rule that this includes addresses with multiple units. So the unit number is part of the address. CMS is going to be soliciting input on situations where the provider-based department must move due to extraordinary circumstances, natural disaster, and this is your opportunity to respond to comments on the proposed rule or respond with comments indicating other types of conditions that would cause you to have to move your provider-based department, because once it's moved, you're going to be subject to Section 603.
You know, some of the things, Cheryl, that we've been noodling, you and me, include, you know, the irrational financial moves that landlords might make, increasing rent dramatically. And if they know that the provider-based status of the department is at risk, if they leave that building, that puts a hospital, and a charitable hospital oftentimes, having additional pressures in an untenable position.
Yes. So you're forced to remain at your, present location. And, right now, CMS doesn't even address if the building's falling down around you, and, the structures doesn't even meet current building code. So either you become a dedicated emergency department or you move on campus. Right, Larry?
I think that's right. And in fact, some of the commentary in the preamble talks about the inability to even purchase or expand into other units within the same medical office building at the same street address as the currently grandfathered off-campus PBD without jeopardizing the grandfathered status.
Right. So now we move into our next polling question, Emily.
Okay, our next question is, are you prepared to modify your billing systems to accommodate CMS's proposal on how to bill for clinics subject to the site-neutral payments? And your options are, yes, we will be ready, no, or great question. I'll give everyone a few moments to make a selection, and for those of you that would like a copy of today's slide deck, you can download them from the folder that says Slide Deck and Handouts at the bottom of your screen. We'll be sending the slides via email after the webcast as well. And let's take a look at the results.
Yes, I agree. Great question. I think people are going to be trying to figure out how they are going to implement this, Larry.
Yeah, we could have put that one down as laughing out loud instead of great question, and we might have even elicited a few more responses.
Yeah. So moving on. The next thing is, here's where you get caught on your grandfathered facility, your accepted department. So let's say you were grandfathered in for as an outpatient hospital department for services that you were billing as provider-based prior to November 2nd. So CMS is preventing those departments from expanding services at the location getting paid under OPPS. So say you're in a building and you want to bring in some additional physician practices. Well, CMS doesn't want you doing that. And so they don't want you expanding at those locations, and they don't want you expanding the scope of services. So this is CMS's way of limiting hospitals from integrating clinical services further. So CMS identifies items and services under a clinical families of services. So what they want to do is your department, your off-campus department, is accepted if you were providing services from a clinical family of services that you were billing prior to November 2nd. If you provide services under a clinical family of services that you were not billing prior to November 2nd, then those services will be billed under other payment methodology, under other payment methodology and not OPPS, such as the Medicare Physician Fee Schedule. But CMS isn't limiting the volume of the accepted items and services at this time. So if you can increase volume of services within the clinical family, you're eligible to do that without being subject to Section 603. So what does this mean? So maybe you have a grandfathered provider-based department, and you're going to have some services billed under OPPS with a split bill, a UB04 for the facility services and a $1,500 for the physician. And then some services outside the existing clinical family of services would be paid under an alternate payment model like the Medicare physician fee schedule. So theoretically, if you have a beneficiary that comes in to a grandfathered clinic, you could theoretically have a UBO4 claim form for the facility component, a 1500 claim form with place of service 19 or 19 for off-campus for the physician component, and then you could have another 1500 potentially with place of service 11 freestanding clinic for services that were provided outside the clinical family of services. So then the beneficiary would have 3 co-pays from 3 different types of billing.
Cheryl, I think this is the most, I want to go back to that slide for a minute. I think this is the most important piece of proposal in the proposed rule for our clients and friends to understand. What it means is that the grandfathered facility isn't really grandfathered as well as we thought Congress meant it to be. What it's saying to me is that it's grandfathered as to those those services that you were billing back last November, but nothing else. And I think that's important for people to understand. It's also important to understand that CMS is not saying that if you add one of those new clinical families, you blow grandfathering entirely, only that those new services can't be billed under OPPS. And I think it's going to be important for providers to be able to track those clinical families for each of their off-campus PBDs so they can be careful that they bill differently for each of those new families. And it probably also makes some grandfathered PBDs more valuable than others because they'll have greater flexibility in the future since they did once bill one of those clinical families.
Agree. This is the gotcha part of the proposed rule. So then if we do go into clinical family of services, Addendum B shows Addendum B of the proposed rule, you know, gives you a list of all your HCPCS codes and the APC code assigned. And CMS has identified clinical family of services, so you might want to consider reviewing your claims to see what clinical family of services you've been providing prior to November 2nd. Because CMS is going to want to know how they're going to track and make sure hospitals are compliant with sticking within their clinical family of services. So CMS considered but hasn't proposed a specific time frame in which the provider-based department had to build the clinical family of services prior to November 2nd, but they're seeking public comment on whether a time frame should be adopted, such as 2013 through 2015 versus, say, just the month of October 2015. I'm hoping that they don't go back all the way to 2013, or if they do, you have a much expanded scope of services. But we want to make sure that anything you build prior to November 2nd would be included in your family of services. So just to give you an idea, there's Table 21 in the proposed rule, and this is it. Whoops. There we go. There's the list of proposed clinical family of services and the applicable APCs. And this is just, and it's all in the 5XXX series. So I went ahead and I sorted Addendum B by APCs just to see what the average payment rate was per APCs. It was just an exercise to see what kind of dollars we're talking about by service type. So with that, I'm going to turn it back over to Larry.
Thanks, Cheryl. Let's talk about some of the other issues that the various provider associations have brought to the attention of CMS over the past few months. One of them was seeking some protection or understanding, at least, of what CMS would say about providers that are sold or merged, or off-campus PBDs that are sold or merged. And their answers are not all that surprising based on how they treat other issues. They specifically said that if the whole hospital is sold or merges into another entity, that the off-campus PBDs will retain their grandfathered status so long as the off-campus PBD generally transfers with the new ownership, and as long as there's not a material change of the provider-based status. I'm going to put a little footnote here, or a warning, that this is either a throwaway line about material change, or it's some suggestion that material changes might affect the grandfathered status of an off-campus PBD, and we just don't know enough about what they meant. We're trying to read the tea leaves a little bit, but I flag that for your future consideration. The other aspect of what they're saying with regard to the sale of the entire hospital is they want to make sure that the new owners or the new hospital accepts the old hospital's provider agreement along with all of their ongoing Medicare liabilities. This is just another stick to cause an acquirer to accept assignment of provider agreement and all their liabilities. It's a due diligence item, but that's the position that CMS has taken. They also said that you can't sell the off-campus PBD out from under a hospital to another hospital and hope that that off-campus PBD will retain its grandfathered status. It won't. And so what they're telling us is, effectively, we don't view grandfathering as a taxi medallion. If the facility leaves the certified hospital, it's gone. I'm curious, Cheryl, about how CMS is supposed to know all these things and what data they're going to collect. Can you walk us through some of the things that they have told us about in the proposed rule?
Well, let's see how easy this is going to be, right? CMS reiterated that hospitals are required to include all practice locations on your CMS 855 form. Do all of you know that you have listed every single location on your 855? It's going to be one way you're going to want to go back and track your various clinics. And so over a 4-year period, CMS was conducting a revalidation process, for people initially enrolled in Medicare or facilities enrolling in Medicare, adding a new practice location, or just revalidating existing enrollment information. However, I'm sorry about this. However, the billing forms do not indicate physical location of services. So CMS is totally unable to automate the process linking enrollment info to the claims processing info. So CMS is asking for information. CMS is asking for input from hospitals if they should self-report so CMS can collect such data, because CMS has no database of provider-based clinics. And so here's the data collection. So CMS, this is your chance to respond to the proposed rule in the comments. CMS is requesting hospitals from you on whether you should be if you should be required to separately identify all individual accepted, i.e. grandfathered provider-based locations. And can each of you identify the date that you began provider-based billing for each of those off-campus departments? CMS wants to know what clinical families of services were provided, and they even offer that the hospitals may have to report the information through new forms available for download on the CMS website, which is the same as self-reporting. So with that, we've got our next polling question, Emily.
All right, thank you. And our final polling question is, how much longer do you plan to stay in the healthcare field? Quitting today, or I'll never quit? We'll give everyone a few moments to make a decision. And as a reminder, once you have completed all CPE requirements, you will be able to download a PDF of your CPE certificate from the certification icon at the bottom of your screen. And let's see what everyone has to say.
That's the spirit. Well, we should have put this one at the end because I'm about to make that answer. I'm about to change the answer. What do you say, Cheryl?
Go for it, Larry.
Let's talk about how these new non-grandfathered services and non-grandfathered locations are going to be billing. And CMS doesn't know a plan for it. They are going to think about it for about a year. And in the meantime, they're going to come up with an interim model. They recognize that there's a lot of interplay between the enrollment rules, the coverage rules, billing, cost reporting. They are aware that their own technology won't really be acceptable for processing claims from hospitals on the UB without and still be billed under a system other than the OPPS. So starting as of January 1, 2017, when Congress said this new system has to kick in, they don't have a new operational solution. They're going to think about a couple of approaches. They will think about having their own new operational solution, and they've also proposed that hospitals could enroll their facilities as a new type of provider, or more likely a supplier, for those non-exempt off-campus PBDs. But there's a lot of warning to be had here, particularly if you're reliant on 340B drug pricing, which we'll talk about in a few minutes. But they're going to think about this for 2018. In the meantime, what they said is, we'll just ask the practitioner or physician who's billing for the service bill under the Medicare physician fee schedule, and we'll pay them at the non-facility rate as an office site, so that the Medicare physician fee schedule payment will be increased, the site of service differential will not be imposed, and that additional amount will somehow compensate the hospital, I guess, for the hospital's overhead. And there will be no separate payment because CMS doesn't pay to the hospital, they think, for the OPPS, certainly for the OPPS service, but they're not going to be paying a separate amount to the hospital. They're going to ask the hospitals and the physicians to work it out. So as I said, there are two options for this coming year. One is to re-enroll as a new kind of entity, and I have some cautions about that. And the other is to have the physician bill for it and somehow work it out. Now, CMS isn't saying how it's going to ask you to work it out, and I think that we're going to have some conversations about that. For example, it's easier if you have employed physicians where the money all goes into a common kitty. It's a budgetary issue, but it's easier than if you have independent physicians who are dropping a claim under a $1,500 and the money's going into their bank account. Those hospitals are going to need to create business arrangements with those physicians in order to somehow settle up. And there are collateral consequences to both of these that are going to be needed to be discussed with your consultants and your legal services. We also are aware that there are a variety of services, even in the off-campus PBD, whether it's grandfathered or not, that aren't paid under the outpatient prospective payment system. CMS mentions only one of them. Those are lab services that can continue to be billed independently, but it really isn't all lab services because some lab services are bundled under the APC, under OPPS. And CMS hasn't said how it's going to treat those bundled lab tests that used to be paid under OPPS, whether they'll allow them to then be billed separately or whether they continue to be bundled and therefore somehow are lost in the shuffle of the new physician fee schedule billing. I think that if you were paying attention to Cheryl's timeline a few minutes ago, one scary thought is that you're going to get notice about what CMS really means to do next fall, and then you'll have 60 days or so to roll out whatever new arrangement you might need with physicians regarding billing and collecting. And one thing to note is that in the Medicare Physician Fee Schedule 2016 final rule last fall, CMS made some specific comments about what does it mean if a physician collects a full fee schedule payment in a hospital department and the hospital doesn't get some piece of that money. And CMS is concerned that that might be a remuneration to the physician and therefore subject to the Stark and anti-kickback laws. While CMS doesn't come out again and say that in this rule, they did specifically solicit comments on what would be the implications under Stark, under anti-kickback, under the reassignment rules, and under the anti-markup rule for diagnostic services. So, if we take a step back here, unless the hospital converts its outpatient department to something else, an ambulatory surgery center, a clinic, or something, they're going to have some sort of a transaction with the physicians, and we're not sure how that will be. Pretty easy, I think, with employed physicians, more challenging with independent physicians, and that will be a source of discussion even before the rule is finalized, because if the rule is finalized as is, you're going to have a very short window of time to enter into those new arrangements. Let's talk about some of the collateral consequences, Cheryl, if we could, about what this proposed rule does and doesn't do to provider-based departments off campus.
So what CMS does say in the OPPS rule is that the off-campus provider-based departments, even if they're not paid under OPPS and would be paid under an alternate methodology, would still be provider-based, meaning they need to meet the conditions of participation and the rules required for provider-based status. The cost reports would report these off-campus departments as ancillary services, so we would report them as provider-based in the cost report. They're just not billed as provider-based. So Larry and I have talked about this, and if that's the case, then those departments would qualify for 340B drug pricing, but CMS has some problems with implementing the payment rates on January 1. And as Larry said, do you change your enrollment forms so you can bill? Well, what would that mean to you in 340B if you changed your enrollment form to a group practice? So those are questions that need to be answered in the coming months. Do you agree, Larry?
I do. I think that CMS was silent on the impact on 340B drug pricing in all 740 pages of this display copy. But the better reading of what they're doing now is that they've done what I think Congress meant for them to do, which is mostly to address the payment of the services. They did not propose to go in and mess with the provider-based rules. They did not mess with the cost reporting rules. They're really just talking about the rate of payment. And I think that was what Congress had in mind, and I don't think Congress ever meant to disrupt 340B drug pricing for these states.
Agreed.
So
with that,
let's talk about what the future looks like. As I said in the beginning, this is just a proposed rule. This is not the law yet. There are comments that are going to be due between now and September 6th, and I urge anybody who's seeing their facilities or strategic plans impacted to get those responses in. But let's also talk about what legislative opportunities are out there, and let me turn it over for our last word to my colleague Jennifer. And Jennifer, could you let us know what's happening on the Hill?
Sure. Thank you, Larry. So folks are probably aware that the piece of legislation that got this all in motion was written very hastily. Congress was looking for a funding mechanism for something else that they wanted to do, and this one scored a significant savings. They kind of acknowledged rather quickly after it was passed that it was written hastily, and there's significant desire in both the House and the Senate among Republicans and Democrats to try to, for lack of a better term, fix some of the unintended consequences. The problem that they're running into is every potential fix, even the small ones, cost money. And it's difficult for Congress to pass anything these days that costs money because they've got to identify an offset somewhere. There has been some progress. In May, the House of Representatives passed legislation that would do essentially two things. It would exclude the cancer hospitals in off-campus outpatient departments from the new payment methodology. The school of thought there is that was a significant unintended consequence, that there was never an intention to include the cancer hospitals in this change. The second was extend the date by which the hospitals had to attest that they were kind of in a mid-build situation with an outpatient department. They extended that until December 31st, 2016. So that legislation passed the House. It's been stalled in the Senate for about 5 or 6 weeks, primarily because, the Senate, they can't agree on what they would like to do. There's a strong desire by some senators whose hospitals would really not be helped at all by that legislation. Hospitals in their state would not really be helped at all, that are interested in going much farther. But again, we get back to the payment issue. My concern is that very significant input from the stakeholders, such as you all, it's going to be very difficult to get anything done this year. Congress is in their final week of session before about a 7-week recess. They come back in September for a couple of weeks. Then they recess again until after the election. So the best chance at probably getting something done, I'm going to speculate, would be in what's called the lame duck session, which would be November, December after the elections. Or we'd be looking at revisiting all of this again next year. The good news is they know that they made some mistakes. There's a strong desire to fix it. But I've been surprised in how few stakeholders seem to be reaching out. Just from the offices that I've spoken with, they're not really hearing from that many people at home. There was a letter that was signed by dozens of members of the House, bipartisan, that went to CMS, asking them to consider a variety of factors when drafting this rule and regulation. Those same members are planning to send a follow-up letter based on what was in the proposed rule. So that's kind of the landscape, and I think without significant congressional input and influence over CMS is likely to interpret this broadly, because it's been a big priority of this administration to identify cost savings in healthcare, and this is one way that they think that they can achieve that. And I will turn it back to our moderator for Q&A.
Great. Thank you, Jen. Lots of questions have come in. If we don't have time to get to your question today, we'll be happy to follow up with you via email after the presentation. Our first question is, how does an RHC, rural health clinic, fall into the off-campus department ruling? Are they exempt from this? Are they considered provider-based inherent in being an RHC?
Emily, this is Cheryl. I'll take that. RHCs are not paid under OPPS, and Section 603 specifically refers to clinics, off-campus clinics that are paid under OPPS or the APCs. RHCs have a different set of conditions of participation and different enrollment process. So they are exempt and not subject to this. Thank you.
Great. Thanks, Cheryl. Our next question is, does multi-campus hospital mean more than one main campus, or does it mean a combination of on-campus and off-campus?
Well,
go ahead.
You want to do it? Go for it. Go for it.
Oh, I was going to say, well, multi-campus is when a hospital has more than one campus location that provides inpatient services. And those inpatient services could be acute beds. They could be, do you agree, a rehab unit or a psych facility, but it's an inpatient location, and then you would be off campus from that other inpatient location.
I think that's the right answer, and I also would add that being away from the main campus has other regulatory implications. So some providers have taken the position that they could have more than one main campus under the same provider agreement, and folks at CMS have been negative about that position or that argument, and that's why I called out the specific discussion in the proposed rule where they flatly say you've got to pick one. Do you want?
Thank you.
Emily, should we grab some more of these out of order as we want to? Because we got a lot of questions coming in. We're not going to finish them all in the next 6 minutes.
Do you want me to start from the top, or go ahead?
Yeah, sure. I was just going to say, one of our friends has asked the question: Is it our opinion that this is really just the first step in completely eliminating all provider-based clinics in the future, whether they're grandfathered or not? And I'll start it off, Cheryl, is that I think that there were a number of people who thought that the BEBA Section 603 didn't go far enough. And certainly there were some like MedPAC who thought that as well. it seems kind of a cruel cut to take this whack and then go back in it again for the on-campus or grandfathered positions, the grandfathered clinics. I personally think that this does a number on all off-campus provider-based departments because, as I said before, they really are frozen in time. You can't move and you can't add new clinical families of services. And that might be fine for a year or two or three, but over time, these facilities are going to become obsolete. They'll be condemned. The services will need to change, and then they're either going to move off on campus or do something entirely different. Cheryl, what do you think?
Absolutely, absolutely.
Could I add to that, Larry?
Oh, yes.
I also just wanted to offer that there was a very heavy lobbying effort for a number of years from the non-hospital provider community, very interested in trying to equalize payments, and that there's no doubt that had a significant, that combined with the fact that this ended up being a cost saver, are really, I think, the two driving forces behind this change.
Yeah, I think that's right. Grab one.
I'm gonna do this one. Let's see. Somebody asked, what about primary care? What if primary care services, our clinic, primary care services? You're going to want to go through your clinical family of services to see what the primary services were, and if that's all it was, then moving into another clinical family of services would not be paid under OPPS. So if you moved into if you were primary care and open radiation oncology at that location, it would not be reimbursed under OPPS.
Yep.
So then there's, let's see.
You want to grab the new one?
The new one?
Sort of the clarification, starting 1/1/17, an accepted facility must bill under the Medicare physician fee schedule non-facility rate. And the physician would bill under this, but what about the hospital is her question. And the answer is, starting 1/1/17, the hospital is not going to bill at all in a non-grandfathered site or for new services that weren't part of that same clinical family. Only the physician is going to bill unless you convert your department to something other than a hospital outpatient department. Your answer too?
I would also add, in some states, hospitals can bill as freestanding entities, so theoretically they would use place of service 11 for freestanding clinic in order to get paid the hospital rate, but there will be no UB04 claim form billing for off-campus departments subject to Section 603. We hope, and CMS discussed in the presentation or in the proposed rule, that they may have to modify their systems. They may come up with another place of service so that the hospital can bill and still get paid the freestanding rate, but they could track that it's being done in a provider-based off-campus department.
Agreed. We probably have time for one more question. You want to take the one right below that one? Because I think that's sort of the key question for those who are concerned about 340B.
Let's see, which one's this one? Grandfathered provider-based?
Yeah, the question is, if you got a grandfathered provider-based department that's forced to move down the hill to a new suite on or after November 2, 2015, is it true that it no longer can bill as provider-based, but it could still be reported above the line on the cost report and deemed eligible for 340B? I think that's our reading.
Yes, we agree. Yeah, if you move out of suite, you may be deemed eligible to 340B, but then you might want to consider the HRSA regs regarding 340B billing. So I think there needs to be some meeting of the minds between HRSA and CMS on this to ensure 340B off-campus eligibility remains. And I think with that, we're wrapping up, and I just want to remind everybody, our firm's healthcare conference is November 3rd and 4th at Red Rocks Resort in Las Vegas, and both Larry and I will be at that conference. There's more information on our website. And then I guess, Emily, you want to close it up?
Sure. Thanks, Cheryl, and thank you, Larry and Jennifer, for a great presentation today. As a reminder, if we did not get to your question, we'll be happy to follow up with you via email after the webcast. And if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet in order to receive credit. This is available to download now under the slide deck and handouts icon at the bottom of your screen. If you participated as an individual and met all certification requirements, your certificate is available now in the CPE icon also at the bottom of your screen. You open the icon and click the printer to download a PDF copy of your certificate. I'll keep the webcast console open for a few moments to allow you to do this now. And a copy of your CPE certificate will be emailed within 2 weeks if you aren't able to download it at the moment. Here's a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey as your feedback is very important to us. And thank you for joining us. We hope you'll join us again next time.